So the only pharmacist that most people know, in fact, before I knew you, is the pharmacist at CVS or
Yes.
Walgreens. So to me, pharmacy has always been like a prison guard in reverse, right? Where they are guarding the drugs, and they have the special license to be able to say, yes, you can have this and this many, and they count out the pills, and it seems like a job that a robot could do.
Yeah.
So what's going on there?
So a robot definitely could do the counting, for sure. What they couldn't do is looking at all of those other things to make sure that it's the right medication for that patient. So again, looking at things like medication reconciliation or a med rec, because you need to make sure there's not duplicates in therapy. There's not the drug interactions. The dose is the right dose for that person. We've had several times too where a patient will bring in their bottle and say, okay, this is what I picked up from the pharmacy. And I look at it and it's not necessarily what the physician meant to prescribe. So it was misfilled. It was probably 4 years ago, I had a patient and he was on warfarin. He came to our clinic, and at our clinic, we usually will call in or electronically send over the prescription for the warfarin because we're doing all of the management of that drug.
So you're not you in your job. You're not sitting there doing the little counting that you always see on the B-roll
I
of
see
news.
no pills in my job. I don't touch a medication. Everything that I do is a one-on-one consultation, looking at things like if the patient comes in with uncontrolled diabetes, where are they in terms of checking their blood sugar, adjusting their doses of insulin, and we're able to do that in the clinic ourselves. So before I came out and visited you, I had a new patient who had diabetes, and she was actually coming in for a couple different things. But for anyone listening out there who has diabetes, her A1C was 12.4. Your A1C is probably in the 4 to 5 range. It's a measure of how high your blood sugar is over a 3-month period. And so she's got very, very, very high blood sugars, and is on 2 different types of insulin. So we sat down and we went through and made adjustments with her insulin regimen that she's taking. And then I'll see her again on Monday, and she'll bring in those blood sugars and we'll look at it and make it another adjustment at that point.
So this is interesting. This is like actually doing what I would have put in the parameters of what a doctor does. It's saying you can look at the test results, and as long as they're within the we know this person needs to be on insulin, but in your pharmaceutical judgment, this is how much you should have, or which specific type of insulin. Or
yes. And the pharmacist is also going to be looking at things like perfect world versus real world. This is something that I always tell our residents that come in. In the perfect world, I might want this insulin, this dosing, this testing. It doesn't matter what we want. It matters what's going to get done. And so there are...
When you say what's going to get done, you mean like, is the patient going to take the pills they're supposed to take?
Is the patient going to take it? Is the insurance going to cover it? And those are the big 2 things. Can they afford it? Is it covered by the insurance? And are they actually going to do it? So if I want someone to be taking insulin 3 times a day, but I know that it's going to be a struggle to do it 1 time a day, well, then let's do it 1 time a day, the best that we can, build that relationship and trust, and then throw in a second dose during the day.
No kidding. This is mind-blowing to me that so you take into consideration whether or not they'll do it.
Oh, yeah, 100%.
That's a flexibility or an aliveness to medicine that I didn't think of, because anytime I've ever been prescribed a medication, I had an antibiotic the other day, and it was take 2 pills 12 hours apart, and that's just what I did. And there was not the doctor didn't ask whether or not I thought I could do it.
And antibiotics are going to fall in a little bit of a different category, but let's say you went and filled that prescription and for some reason it was going to be $400 to take. That's where the pharmacist should come in and say, okay, well, these are maybe some other cheaper options that if it's going to be nothing or this, what is this that we can get to?
And so how much flexibility? So if I'm going back to the Walgreens CVS pharmacist, I come there with the prescription that says I need this particular medicine. What's their flexibility, or do they just fill that bottle?
They a lot of times will probably just fill that bottle because they are understaffed and overworked. So when people come in and say, why does it take 10 minutes to slap a label on that
That's exactly what I think.
Box back
yes, that's
there.
right. Wait, what, 25 minutes?
So it's not a fast food restaurant. What you don't see is the 100 orders of medications they've got in the queues. The doctors, they're calling about these potential problems or suggesting an alternative. And retail pharmacists from when I started to now have become so overworked. You probably don't realize that your pharmacist is working a 12-hour shift, doesn't get a lunch break, and gets UTIs because they can only pee twice during the shift because they can't leave the pharmacy.
Really?
Yeah. So their managers at those stores a lot of time is the manager of that CVS or Walgreens store. And all they care about is the money and the numbers. Whereas in pharmacy, the pharmacist is hopefully their number one concern, the patient. So if a pharmacist wants to go slower to be able to make these interventions, they'll probably get fired because they're not going to fill enough prescriptions and not make enough money for the pharmacy.
But medicine is so expensive. It's surprising to me that they have understaffing issues at a thing like Walgreens.
Yeah.
And is that what would you say that's a function of?
Money.
Too many Walgreens? Like
too many, they want their bottom line to look as good as it can. And so pharmacists have historically been great at getting things done. And so they'll get it done being understaffed. Does that mean there's higher burnout? Does that mean there's higher medication errors? Does that mean it's not the best thing for the patient? Yes. But that manager of that store wants to look good. And if the pharmacy is the money-making point, when you have a pharmacist that makes six figures, even adding half a pharmacist extra is a lot of money that's going to take away from that bottom line, and they don't like to do it.
And so if a person comes into a Walgreens, CVS, and they say, I want this medication, they find out how much it's going to cost, they go crazy. The pharmacist has the power to change that? Or
No.
Okay, so what happens then?
So in that situation, the pharmacist would have to reach out to the doctor to make a change. In the situation that I'm at, we have collaborative practice agreements with the physicians. So that patient that I saw on Wednesday, it says diabetes management, and that includes being able to change their insulin, which actual insulin they're on, and the dosing of that as well. So I have a lot of flexibility with what I do. Retail, their hands are tied in terms of they can't make any of those changes without having a touch point with the physician. And again, that's time, So that person's ahead of you getting your antibiotic, their antibiotic's not covered. The pharmacist is taking 10 minutes to try to get that resolved. You're even more upset that you're having to wait longer because you don't see anyone in line. The pharmacist is just back there and you say, what's going on here?
So the retail pharmacists, it sounds like it is just as bad of a job as I imagined it to be, sitting in the back. Okay. And what else makes it worse?
I think that and there's definitely friends that I have that love their job, that enjoy their job, that have good employers. So I don't want to say that all of those are negative, but next time you go and get your prescription filled, asked, do you feel that your pharmacy is appropriately staffed? And I would definitely feel comfortable saying at least probably 75% or more of retail pharmacists would say, no, we need more technician hours. We need another pharmacist. They don't feel significantly staffed.
And there are other people in the back there that are not pharmacists, they're pharmacy techs. So what's the difference? What's going on there?
So a pharmacy technician is someone who just goes and I haven't worked in retail in so long. I don't know the minimum requirements, if it's like a high school graduation, and then they have to, within a 3-year period, take a test and become certified. I think that's what it is, but I'm not 100% sure. So they're the ones who are maybe getting those things ready for the pharmacist, or, counting by fives the medication that then the pharmacist double checks. So they're trying to take everything off the pharmacist's plate that they can, so that the pharmacist can, in theory, do those higher level type things.